انا مش ليا انا بس كاندوكرينولوجيست، لا كلنا بنشوف حالات الشورت ستاتشر، وحضراتكم شايفين الطياره اللي عماله تقع دي. mistakes cost a lot. احنا ممكن لو عملنا حركه واحده غلط اللعبه كلها تبوظ. فمهم جدا ان احنا مهما كان الحاجه simple اللي هي short stature نحاول قدر المستطاع to follow the rules. وبقيه القصه انه when you follow the rules you take a very nice journey زي الطياره اللطيفه اللي بتتفسح. بس العكس بقى when you do not follow the rules لا ممكن الامور ما تبقاش لطيفه ابدا ويحصل mistakes ما نعرفش نصلحها. عشان كده be careful not to fall when dealing with the diagnosis and treatment of short stature, because short stature is not that simple as you might think. So the question is how to hit the target when dealing with a child with short stature. This is the proposed algorithm by European Society for Pediatric Endocrinology. And as you see, we take a good history, physical examination, general investigations. We do endocrine assessment in the form of thyroid functions, growth hormone stimulation test, IGF-1, and finally genetic studies in very selected cases. So which way shall we go? And this is important to answer, to give or not to give growth hormone. Recombinant human growth hormone is obtained by genetic engineering. And as you see, all these children came to me with short stature. All are different scenarios and diagnoses. But the question is, who will benefit from growth hormone? Now, let me take you to some case scenarios to apply the pitfalls. This is a 14-year-old boy who came with short stature and delayed puberty. The father was short with delayed puberty and catched up his height later. If you look at the growth chart, the boy was born normal, and then he started to decelerate in childhood, and more deceleration occurred at the time of puberty. Now, the boy was found to have microcytic hyperchromic anemia. The calcium was lowish. As you see, vitamin D was low as well. Celiac screening and thyroid function were normal. The pediatrician asked for basal growth hormone, and it was found to be low. Now, let me ask you, does this diagnose growth hormone deficiency? Who says yes? Thank you very much. A very big no. Of course, this does not diagnose growth hormone deficiency. And the pediatrician did a GnRH stimulation test. The child was found to have low FSH/LH and testosterone. The bone age was delayed 10 years, and the boy is 14, and the height age is 10 years. What's your diagnosis? This is constitutional delay in growth and puberty. But the pediatrician did not diagnose the child this way. He started growth hormone. So what are the mistakes or pitfalls in this boy? First of all, we do not rely on basal growth hormone at all. When we decide, we do growth hormone stimulation test. Constitutional delay in growth and puberty is not treated by growth hormone. You have to improve nutritional status. And this is what we did. We gave vitamin D, calcium, iron, and zinc. And with nutritional support, the boy catched up his height and reached a very good final height, taller than his dad. So this is a 7-year-old girl who came with very much short stature, -4.5 standard deviation, poor growth velocity, 2 centimeters a year, doll-like face, abdominal fat being excess, and normal IQ. And as you see here, she started to decelerate the height at the age of 3 years and then plateaued the height completely. Now, the celiac screen was negative, cortisol, ACTH is normal. Look at the thyroid function. Borderline low T4 and high TSH. Again, pediatrician did a basal growth hormone. It was low, and the bone age was very much delayed. So this is a case of hypothyroidism plus growth hormone deficiency. What are the mistakes or pitfalls done by pediatrician? Again and again, don't rely on basal growth hormone to diagnose growth hormone deficiency. Correct hypothyroidism first before doing growth hormone stimulation test. Because if you do growth hormone stimulation in a child with hypothyroidism, you're going to get false low growth hormone test. So this is a false positive test. Now, we started thyroxine and the thyroid functions normalized, and we did growth hormone stimulation test. It was low, and the IGF-1 was low, and MRI celatosica showed anterior pituitary hypoplasia. What is the next step? We started growth hormone at the proper dose, as you see. And here you can see the criteria for diagnosing growth hormone deficiency proposed by Growth Hormone Research Society. And remember, the cutoff for diagnosing growth hormone is less than 7 nanograms per ml by 2 stimulation tests. Another important question, do we always need to do 2 growth hormone stimulation tests to assess the growth hormone IGF axis? The answer is no. There are some exceptions. You can do only 1 growth hormone stimulation if there is a definite CNS pathology, history of cranial irradiation, proven genetic defect by genetic testing, or congenital malformation by MRI. Also, you do not need to do a growth hormone stimulation test at all if you have the diagnosis of Turner syndrome, Noonan syndrome, Prader-Willi, infants born SGA, and chronic renal insufficiency. If you have this diagnosis, don't do a growth hormone stimulation test. Now, back to our case, we gave thyroxine, growth hormone, and the girl grew beautifully well and reached a good final height. Another important point is that the dosage of growth hormone differs in different periods of life. You have to adjust the dose according to whether this is a child, adolescent, or adult. What about this 6-year-old girl who came to me with severe short stature, weight loss? Remember, she's thin and short at the same time. She has abdominal distension, recurrent diarrhea, thinning of the limbs, and she was born normal with normal IQ. Do you think this case fits with an endocrine disease? Thank you very much. Of course not. Endocrine disease will be short and obese. But when you have short, thin child, think of nutritional disease or GIT. So here you can see she was born normal. She started to decelerate, especially with introduction of food with the weaning. And you can see here that she started to lose weight as well when the mother started to introduce food. Now, the girl was found to have anemia, 8 grams per deciliter. The calcium was low. Thyroid function is normal. The pediatrician this time did a growth hormone stimulation test. It was normal. Do you think it was correct to do a growth hormone stimulation test for such a case? Of course not. This is not endocrine. The bone age was 1 year delay. This is not endocrine. The endocrine causes 2 years or more delay. Again, the pediatrician is convinced that this is short. He gave her growth hormone. What are the pitfalls? What are the mistakes here? Yes, there is no need to do a growth hormone stimulation test. Screen for celiac disease in any short child, even in the absence of GIT symptoms. The ideal treatment is not growth hormone here. It's a gluten-free diet. Correct vitamin and mineral deficiency. We only give growth hormone if the child does not catch up on gluten-free diet after 6 months. We did tissue transglutaminase. It was very high, and this was confirmed by biopsy. The girl is doing very well on gluten-free diet. The other indication is SGA, and this is a birth weight or length below -2 standard deviation. As you know, 3 subclasses of SGA are recognized, either SGA regarding length, weight, or weight and length. Now, let me take you to the story of this full-term neonate born SGA. His height is very low, -2.8. The BMI is normal. The mother came to the pediatrician at the age of 1 year requesting growth hormone. She's very upset. The child is very short. And he decided to start growth hormone. Is this the correct decision? No, this is not, of course, the correct decision. Simply because 85 to 90% of SGA catch up spontaneously without treatment at the age of 2 to 4 years. So you have to wait. Only 10 to 15% do not catch up and require growth hormone. Again, growth hormone stimulation test is not needed in such a case. Growth hormone is approved for short SGA babies who did not catch up till the age of 2 years according to FDA or 4 years according to EMA, and it's given until complete epiphyseal closure. And you can see that the final height improves a lot in those children. What about this 13-and-a-half-year-old girl? She came with short stature and delayed puberty. She was born with low birth weight and length, swelling of the dorsa of hands and feet, mathematical problems at school, and otitis media. If you look at the chart, she was very short since birth, childhood until adolescence, when she presented to the pediatrician with short stature and delayed puberty. Thyroid function, celiac screening, growth hormone stimulation were normal. The bone age was delayed. GnRH test revealed high FSH, LH, low estradiol. So this is hypergonadotropic hypogonadism, meaning that there is a problem with the gonads. She also has a horseshoe kidney, and the echo is normal. What did the pediatrician do? He started estrogen therapy for delayed puberty, and then growth hormone therapy on the growth hormone deficiency dose. What's the missing investigation here? Thank you very much. Of course, this is a very important pitfall. She proved to be Turner syndrome, 45X Turner syndrome. And that's why karyotype is indicated in any short girl or any girl with delayed puberty or left-sided cardiac anomaly, even in the absence of dysmorphic features. Another pitfall was growth hormone test. It's not needed. If you have a karyotype diagnosis of Turner, you do not need to do it. Also, we have to start growth hormone therapy before sex steroid replacement. Another point, Turner syndrome require larger growth hormone doses because they have growth hormone resistance rather than deficiency. So if you give growth hormone deficiency dose, they will not respond well. Now, the girl was referred to the pediatric endocrinologist, and she was given growth hormone, and she's doing very, very well. Now, this is a 12-year-old boy who came with short stature, obesity. He was born SGA. He was very floppy at birth. And then he started to develop hyperphagia, progressive weight gain, learning disabilities, small hands and feet, small scrotum, and micropenis. What's your diagnosis? Thank you very much. This is the typical Prader-Willi syndrome. And if you look at the chart, the child was born SGA, and then he started to be short. More deceleration occurred with adolescence. Regarding the weight, he was born SGA, and then he started to develop dysphagia at the age of 3 years. So we are facing a case of obesity and short stature in a child with learning disabilities. And the parents gave history that the child could not stop eating to the degree that they have to lock the fridge because the child has no satiety at all. Prader-Willi occurs due to loss of expression of paternal alleles in Prader-Willi region in chromosome number 15. And to confirm the diagnosis, we need to do FISH. Indeed, there is impaired growth hormone IGF axis in Prader-Willi, either in the form of growth hormone deficiency or resistance. And there's a very long list of comorbidities that we need to screen for in those patients, like hypogonadism, adrenal insufficiency, hypothyroidism, growth hormone deficiency, type 2 diabetes, and sleep apnea. And this is what we screened in this boy. We found low T4 and low TSH. This is central hypothyroidism. And the rest was normal. The child also had impaired fasting blood sugar and glucose tolerance. What did the pediatrician do? He decided to start growth hormone immediately in the growth hormone deficiency dose. What are the pitfalls here? What do you think? Thank you very much. Yes, we have to correct the thyroid function. We have to do polysomnography, ENT evaluation, adrenal, thyroid, glucose homeostasis. All of these should be corrected first before starting growth hormone therapy to avoid sudden death and comorbidities in those children. Again, if you have the diagnosis of Prader-Willi, you do not need to do a growth hormone stimulation test. Also, we need higher doses of growth hormone because they have a growth hormone resistance. And the benefits of growth hormone in those children is linear growth, body composition, motor and psychomotor development. Now, this is a 14-year-old girl diagnosed with chronic kidney disease. She's very short, -3 standard deviation. She started puberty, and the bone age is 12 years. Other pituitary hormones are normal, and thyroid function is normal. Growth hormone stimulation was not done. The pediatrician started growth hormone therapy because she's very short. Is this right or wrong? Yes or no? Yes. المرة دي yes. Yes, it is approved to start growth hormone in chronic kidney disease, even without doing a growth hormone stimulation test. Because there is impaired growth hormone IGF axis in those children, they respond very well because they have impaired calorie intake, acidosis, kidney, insufficient electrolyte balance, uremic milieu, delayed puberty, a lot of problems that are improved a lot with growth hormone therapy. So yes, it is an approved indication. And they need higher doses because they have resistance. Now, the second part of the story is that the girl was referred for renal transplantation. She did renal transplant, and she came 3 months after transplant to the pediatrician. She's still short, and she asked the pediatrician to restart growth hormone because she's still short. The pediatrician restarted growth hormone again. Right or wrong? This is wrong. Yes, thank you very much. It is not approved to start growth hormone in those on renal transplant because it increases the incidence of rejection if you start before 1 year. If 1 year passes and the child is not improving, you can start, and as you see, it improves the growth velocity very well. So finally, after seeing this panorama of short children with a lot of mistakes being done by people who are not practicing short stature well, I think you agree that early diagnosis and proper treatment of short stature improves the final height outcome, whatever the cause. It doesn't matter, but you have to start early and diagnose early. And when you see a case of short stature, be careful not to fall in the pitfalls because it could mislead you to an improper diagnosis and treatment. So what if time is critical at the time of puberty? Again, correct decision counts a lot. It's even more critical at the time of puberty because sometimes we need to buy the time. It costs a lot to diagnose and treat properly to avoid this very sad story that I see every day. An adolescent coming to me, asking me to give growth hormone. And when I do the bone age, I find complete epiphyseal closure, ending up by a very short adult who is psychologically affected by the condition. And what I say, unfortunately, time cannot go back. So I think prevention is better than treatment. We can diagnose and treat early. And we have to balance the decision on individual case. Because as you've seen, each case has got its own story. You have to go according to the story of each case. And let me tell you, children with short stature are very clever and charming. I think you agree. They deserve a better quality of life. And I think you agree that short stature affects the quality of life of those children. Their performance at school, their performance with their children, attaining a job, and a lot of other things is affected by stature. I see those children the first visit when they are so frustrated, and I see them after they get taller and they gain self-confidence and become very successful people later on. So I think we need to help them to diagnose and treat quickly and to score a goal like this amazing goal scored by Mo Salah. We need to do the same as pediatricians and as pediatric endocrinologists to have a safe flight. عايزين الطيارة تبقى كده مش زي الطيارة الأولانية اللي دخلت وcrashed في الجبل. لا, we need to have a safe flight with those children. So the bad news is time flies, and the good is you are the pilot. Thank you very much for your attention.